Thank you very much, and also for allowing me to deliver this lecture online. And unfortunately, I had another commitment which did not allow me to be in presence. Let me now. Okay. In my topic today, I'll try to share with you a long journey. Long journey which lasted about 30 years. And let's start from the beginning. The beginning was in the early 90s. In those days, I introduced a different way of treating depression, which I define as sequential treatment. There was nothing new. I mean, sequential treatment was in use in medicine, but in psychiatry it was had not been practiced. It consisted in the use of antidepressant drugs for the treatment of the acute episode of depression, and use of psychotherapy for the residual symptoms of depression after obtaining remission. And then there were two possibilities. One was that antidepressant drugs were tapered and discontinued, and that was our approach, or another version of the model that could be continued. In those days, the principal investigators were actually working in assessing and many times treating the patients. So there was a first trial we did in Italy that was with 40 patients who had been successfully treated with antidepressant drugs. In those days were mostly tricyclics. The SSRI were just beginning, and they were randomly assigned to either cognitive behavioral treatment or clinical management of residual symptoms. And in both groups, antidepressant drugs were tapered and discontinued. And I remember I didn't find any problems in tapering and discontinuing antidepressant drugs in that population. The group that received sequential treatment, something that can create some confusion. Sequential means first you do pharmacotherapy and then you do psychotherapy, and the two treatments are not administered at the same time. And the group that received the experimental treatment did better in terms of relapse rate compared to the control group. We performed another study on recurrent depression.
Professor Fava, sorry for interrupting. Probably you didn't make a screen share.
I did, but okay. I'll try to. Well. Let's see. I did. I'll do it again. Can you see it?
Yeah.
Oh.
Okay.
Apologize.
So we missed the first 5 slides.
Yeah, the 5 slides. So let's start from this slide because it's the same concept. We did this study and we randomized patients to a combination of cognitive behavioral treatment and well-being therapy versus clinical management. And also in this study, antidepressant drugs again, mostly tricyclic antidepressants were tapered and discontinued. Again, didn't find any problems in tapering and discontinuing antidepressants. Then we had a very long follow-up, 6 years, well-being therapy and cognitive behavioral treatment resulted in they were more effective than clinical management in preventing relapse. And you can see the outcome in this slide when you see the patients who were treated with the combination were well and drank, more than 50% at 6 years, while the other group, almost anyone relapse. At that point, this type of approach, sequential, was used by other investigators. A couple of years ago, we did a meta-analysis with Jenny Guidi of these studies, which used a sequential model. And the meta-analysis showed that the sequential integration of psychotherapy after pharmacotherapy was protective against relapse and recurrence in major depressive disorder. The fact that the patients were no longer taking medications or they continue medication didn't seem to matter. And there are now 17 randomized controlled trials on this approach, which is the only approach that is associated with long-term benefits after the administration of the approach. And in those days, again, I was not particularly concerned about tapering and discontinuing antidepressant drugs. But there was a wake-up call. Once I was seeing a patient called Alan. He was a 43-year-old executive with a 4-month history of major depression. And he had been treated by his primary care physician with paroxetine, 40 milligrams per day, with little response. So I thought, well, why don't I switch him to diazepam, 50 milligrams per day, after reducing paroxetine to 20 milligrams for 3 days. But Alan called me a few days later and was extremely worried. I have to see you as soon as possible. And when he came, he reported very severe symptoms, agitation, aches, pain, but even visual hallucination. And I remember his remark to me, his question, what is going on here? Well, what is going on here? I didn't know. In the literature, in that moment, there were no reports. Of course, I tried to reassure him, and fortunately, a few days later, the symptoms started decreasing, and the patient felt better. I thought, well, probably I was too rushy in changing the medication, and I should have done it more slowly. But an increasing number of reports then started appearing in psychiatric journals, mostly. There were only SSRI, about this severe withdrawal reaction. So they didn't happen to me only. I mean, there were other investigators that were reporting. So what happened is that the pharmaceutical industry intervened in the sense that the withdrawal syndromes should be called discontinuation syndromes. And the term withdrawal disappeared from the literature with the implication that they occur only with abrupt tapering, sudden tapering, and they were going to last 2, 3, 4 weeks at most. And the guidelines of various organizations endorse this view. Clinicians like me knew that it was not true that withdrawal discontinuation syndromes occurred also with slow tapering. I mean, you just start touching the dose and the patient may develop symptoms. Yes, in most of the cases, they persist for 2 or 3 weeks, but could be prolonged. But clinicians, I believe, had a very difficult time then because I use this example of the emperor. They were reluctant to voice that the emperor had no clothes because the scientific literature was so compact in praising the emperor's clothes. It's no problem, it's not withdrawal. There's nothing like this. If you go slowly, you're not going to have problem. Fortunately, not all researchers follow this trend. I decided to design the study. And the aim of the study is to see whether this was really the idea behind mine. Let's take a sample of patients in the best possible conditions. These were 20 patients with panic disorder and agoraphobia. They've been successfully treated with a standardized behavioral protocol based on exposure only. They have been treated by me. So the patient trusted me. We developed a good relationship. All these patients were taking SSRI at the entry of the study. I mean, they had panic attacks even with SSRI. At that point, they were fine. They no longer panicked. Their mobility had increased. Let's taper the SSRI and then discontinue. And I thought this design, they're not going to relapse so easily because of the type of treatment. I'm going also to handle tapering and discontinuation. And my prediction was we'll only find a few cases. But 45% of patients reported a withdrawal syndrome, which stopped in a month, except in 3 patients were taking paroxetine, and it continued at the 1-year follow-up. So through this study, I really had the feeling that something was going on, as Alex said, and we had to find out the mechanism more. This type of study, in terms of case report, had been done in Canada by one of the most important psychopharmacologists today, Guy Chouinard. And so I tried to get in touch with him. And I remember he came to Italy, and so we met in a cafe close to a train station, and we discussed all this method. And this was really the start of everything. Yes, we were only 2 people, but I was not alone. And we decided to do something. And I had a journal to support my statements. So what we did, my group, we examined the not being systematic reviews before. We did one in that we published a few years ago on SSRI, and later another one on dual reuptake inhibitors. Gishina developed diagnostic criteria for this phenomena, and I'm going to show them to you in a second, and differentiation with other syndromes. The conclusion of this review was very, very clear. It makes no sense to keep on talking about discontinuation syndromes. We should talk about withdrawal syndrome as it applies to benzodiazepines and other psychotropic drugs, and we should face the problem in a very different way. And it is with some pride, I must say, and satisfaction that saying that now some guidelines have changed. For instance, NICE guidelines, and researchers are talking about withdrawal syndromes again. The use discontinuation syndrome is not justified by the data. But let's look at withdrawal symptoms. You see, this is I apologize, I forgot. This is a list of symptoms. And you see, it's very, very different symptoms at very different levels. And what, however, is important, a characteristic, is that these are new symptoms. I mean, the patient didn't have the symptoms before. Schunar elaborated some diagnostic criteria for withdrawal syndrome from antidepressant medications. That was the presence of at least 2 new withdrawal symptoms that were not experienced by the patient before, with a certain type of course, with a peak of onset very variable, but within generally 110 days, and symptoms that were causing distress. So there was a certain threshold. We now know from systematic reviews that almost half of patients for which antidepressant drugs are tapered and discontinued experience some withdrawal symptoms. But in this case, we have a threshold. And then there were also diagnostic criteria for this condition, which is persistent post-withdrawal antidepressant discontinuation syndrome. That is the fact that these symptoms, as the 3 patients in our study with paroxetine, don't stop after 1 month, 2 months, continue, or the new symptoms, new disorders develop that were not present before. We don't really have good data about the prevalence of this condition. There's very, very little research in this area. I know it's not very popular, but these patients, nonetheless, they exist. And then I was concern about other clinical phenomena. You see, we are talking about withdrawal symptoms or syndromes. They are present, but as a clinician, I started observing other clinical phenomena, and I'm sure that the clinicians in the audience, they all have experienced this phenomena. The first is loss of clinical efficacy. What is? You have a patient who's doing well on antidepressant drugs, at a certain point stops doing well as a relapse. The patient is taking the medication. It's not a matter of compliance. Sometimes you increase the medication, things get better for a while. This is something that happens quite frequently. We have only one placebo-controlled well-done study with fluoxetine that shows that takes place in 1/3 of the patient with 6 months of continuation. Then we have paradoxical effects. The fact that a deepening of depression, for instance. Switching, what is switching? Patient on antidepressants develops hypomania or mania. At the beginning, the investigator will say, okay, it's because of bipolar, latency and so on. But now we have data that show that really unipolar patients may also develop hypomania and mania. And this phenomenon is particularly worrisome in children and adolescents. Resistance. The way I use the term resistance here is not the usual one. Resistance here is something very specific. The fact that you have a patient who responded to medication, then you stop the medication, give the medication again, and no longer responds. And refractoriness is what people generally mean for treatment resistance. And all these manifestations appear to be sort of interrelated. And what I did, I tried to build a unitary concept. What is? The fact that what is shared by syndromes such as withdrawal, loss of efficacy, switching, and resistance may be as important as the differences between them. And conditions that are apparently comorbid are part of the same clinical syndromes. So I developed a model that I found practical use, the oppositional model of tolerance. And substantially, you have a certain type of treatment that triggers, may trigger processes that oppose the initial acute effects of a drug and may result in loss of clinical effect. And when drug treatment ends, these processes find no opposition, at least for some time, and then maybe also increase vulnerability to relapse. And you see the model described here. We have early treatment with this phenomenon, long-term treatment where phenomena like loss of clinical effect may delayed side effects may appear, and post-treatment with withdrawal, post-withdrawal, and all other phenomena. Then I decided during one of the lockdowns to write down a book for sharing my experiences, also as a clinician, and sharing also the literature that I had consulted about this problem. This book has been translated in various languages, and it will also be translated into Turkish. Because clinicians have to discontinue. There are situations where you have to discontinue medications, or because of side effects, or lack of loss of efficacy, or the fact that we often don't know. When I get patients from primary care physicians, I never know why the antidepressant was prescribed, or the patient is getting better and wants the medication to be discontinued. And if you just use DSM, we do very, very little. And we need to assess patients in a different way. And I'm going to give you an idea about this. But let's go back to one issue. In those years, early 90s, with Robert Kellner, my mentor, we introduced the concept of staging in psychiatry. Again, we didn't invent anything. I mean, the staging, of course, was well practiced in clinical medicine, oncology, cardiology, but not in psychiatry, and so it may be very helpful. Using this model of staging, we may have patients and taking all these manifestations together as related, patients may have different levels of these events reflecting the positional model of tolerance from 0 to 4, which tells you a little bit about how tricky the problem is going to be. But then it's very individual how to do it, when to do it, which strategies, because you have to take into consideration a number of variables. That is individual variables and a lot of other characteristics. So there are also different methods. Abrupt stop means that you move from one medication to another with no, for instance, no interruption. Rapid tapering, slow tapering, ultra slow tapering. I mean, there is a method that has become very popular, ultra slow. It takes years to discontinue a medication. Big Pharma loves this last method because people keep on taking medications for years anyway. So there are pros and cons in any clinical decision because maybe the symptoms are fewer, but there is no evidence right now that slower methods are better than more rapid methods, but you prolong exposure to the medication. There is also the question, Shina was convinced, shared with me that for tapering and discontinue antidepressant medication, you need to add an anticonvulsant. And I follow his advice. I've been using clonazepam, which is, because also its anti-anxiety properties may be particularly suitable. And of course, there is no randomized controlled trial for this, but this is another perspective that I added. And then this is this, not going to describe in detail also because we are pretty late. And but just to give you the idea that things are more complicated when you decide to discontinue medication. I mean, it takes a second to prescribe them, but it's a tough job to take them off. And there is a part that the patient need to be aware of what's going on, and this is sort of something that I always thought was important. So explanatory therapy, CBT should be used, and then well-being therapy, because otherwise the patients are so much convinced that, I remember a colleague, and she was doing much better, but she shared with me, I've been taking these antidepressant drugs for so long, I'm a weak person, I cannot do it without it. So you need to use also psychotherapeutic strategies, and this is well-being therapy, which, however, it's a very specific therapy with monitoring of psychological well-being. But just to give you an example, if you have a patient who has been taking antidepressant drugs and has an anxiety disorder, okay, when you discontinue, the literature is pretty clear about it. When you discontinue the antidepressant drugs, if the patient didn't have any form of psychotherapy, in addition to medication, 90% of cases, the patient is going to relapse. So if I want to take the medication off and the patient is panic-free, for instance, I have to do psychotherapy to make the patient feeling better. And this is the other. We don't need to get into details, just to share with you the complications that I found in this sense. But let me, in meetings generally, I mean, big concepts, discussion about general matters, but let me consider one case. And through this case, you're going to see how we work with these patients. And we have an Italian lady, Roberta, is a 64-year-old married woman who presents a major depressive disorder, 8-month duration. The primary care physician prescribes sertraline, up to 100 milligrams, but no response. She complained of persisting nausea, and she even wondered whether it could be caused by sertraline. But her primary care physician said, no way. Prescribed several anti-nausea drugs with little success. She kept on feeling bad. So the doctor prescribed venlafaxine, first 75, then 150. No improvement in mood, but worsening of nausea. Again, the doctor said, it's not venlafaxine. It has to do with stress. But at that point, said, well, I'll refer you to a center, and they probably give you something stronger. So, and this, let me put this note, the spectacular achievements of propaganda. A lot of doctors are of the side effects that antidepressants may induce, particularly long-term, and nausea is very, very common symptom. So I try to inquire a little bit about how she developed depression. There was no previous history. There was substantial weight loss in the past year. But my concern was with the life setting. What happened to her? And Professor Cloninger in the previous lecture was emphasized so much the biopsychosocial model, and we need to do it also in clinical practice. Roberta didn't report any problems until a couple of years before. when she and her husband decided to sell their bakery and to retire. Shortly afterwards, she became very anxious, nervous, limited her daily activities, developed a major depressive disorder with sleep problems, fatigue, ruminations, avoidance. And she stayed at home most of the day, missing the bakery days. I really got the feeling that if I could place her in a bakery with the children waiting for the croissant and so on, that would have been a great antidepressant treatment. But I couldn't do it, so I had to find something else. It's called moral analysis, but it's something every clinician knows and does. You put together the problems of the patients. Let me just add that only psychiatrists in the entire field of medicine limit comorbidity to diagnosis. The rest of medicine, comorbidity means also problems that do not reach the threshold of a diagnosis. So, okay, yes, we have a major depressive disorder with rumination. We have agoraphobic avoidance, and we don't know really the relationship, which then gives some problems with the husband. The husband was looking forward to being retired, for doing things, and this is not going on. Venlafaxine causes nausea and stomach burning, but she starts wondering, well, I know so many people who got cancer after they retire, what's going on to me? And again, anxiety going on. I use, I know that there are not many psychiatrists who do that, shared decision. There are a lot of cardiologists, diabetologists who do that, but not that many psychiatrists. So I explained to her that the medication she was taking is likely to cause nausea. But there might be some problems when you discontinue it. There was a withdrawal reaction from switching from sertraline to venlafaxine. So shared decision means, do you prefer a rapid switch that is likely to cause more distress for a few weeks, or a gradual one? And the answer was clear-cut. For God's sake, get me this rubbish out of my body as soon as possible. So I followed the order. Substitute venlafaxine with, I use mirtazapine because of the stomach problems. At bedtime, the very same day, no intermediate step. And she was asked to call me in a week and to come back in a month. However, I always tell my patients the new medication would improve your symptoms, in this case nausea, but contribute at best 50% to you getting better. And so I write one prescription with mirtazapine, but I always write a second prescription that is called self-therapy. And where I write down very simple things that she needs to be doing, a little bit of behavioral psychotherapy. It's not psychotherapy. These are some indications, and she had to get out of the house, visit the children, go out every afternoon with husband, so on. Then you see that my approach, I'm not using antidepressant medication only. I'm using homework exposure here, and I'm giving some explanation about what's going on here. What happens? After 1 month, her nausea improved a great deal. Her depression, in part, I mean, certain symptoms, but she was still spending most of her days at home. So, again, shared decision. You're doing better, but not well. We have now two choices. Either we increase the medication dosage, or you work more on the task I assigned to you. And she replied, you put your 50%, I'm sure, I'm positive. I put only 10, 20% of mine. It's my turn. I must do more. Let us keep the medication as is. I have your second prescription. And 4 months later, she was definitely better in terms of some of anxiety, some rumination, some discussion, but sort of unremarkable. Mirtazapine was discontinued without any problems, and patient as well at a 4-year follow-up. So the concept is really the patient as a health producer and not a customer, as we tend to conceive these days. And let me conclude with a couple of patients. One, it's really wishful thinking to believe that one course of treatment may solve the complex problems encountered in practice nowadays. One course of treatment, whether pharmacotherapy or psychotherapy, we have very complicated cases, and the sequential model based on repeated assessment, staging, macroanalysis, consideration of iatrogenic factors, individualized targets, require collaboration of different specialists, should be considered in all cases of major depressive disorder, and particularly if you want to taper and discontinue antidepressant medication. This is a complex task that requires appropriate structures. Antidepressant medications are life-saving drugs, but this is what I've become convinced after so many years dealing with this patient. We need to target their application only to the most severe and persistent cases of depression, limiting their use to the shortest possible time. I know that I'm going against all indication, but the shortest possible time in an event cannot be less than 6 months, and reducing their use in anxiety disorders, unless a major depressive disorder is present or other treatments have been ineffective. So my conclusion is that we can wait, hopefully, in new wonder drugs that may change our practice, or we may practice a highly effective psychiatry now. Thank you very much for your attention.